Breathing is the first principle according to Pilates and also according to Polestar principles of movement. And the take-home message for us regarding breathing is that movement facilitates breath and breath facilitates movement. Maybe another way of thinking about this, sometimes we get caught looking for rules of breath, but the body's very dynamic. And one of the things we want to be able to do is to breathe in all conditions and all orientations of gravity. So I sort of made up a little phrase that says, breath is a tool, not a rule. So we understand that movement and the importance of movement in our body, breath facilitates that, particularly in the thoracic spine and the lumbar spine. So let's delve into some of the anatomy to help us better understand breath and what it does for us. First, we can start off with the principle that Joseph shared with us. One of his quotes, it said, "Your blood will flow with renewed vigor as a direct result of your faithfully performing the contrology exercises. These exercises induce the heart to pump strong and steadily. As a result, the bloodstream carries and discharges from your system more of the accumulated debris created by fatigue." Joe was way ahead of his time. If you think about the #1 cause of death in a hospital today, it's respiratory failure. People come in with a fractured hip and die from pulmonary failure, pneumonia, respiratory collapse. These are all things that happen because people don't have good respiratory habits. The air pools in the bottom of the lungs. Why? Because the rib cage doesn't move. If the rib cage doesn't move, that old air sits down in the bottom of those lungs and those alveoli, and the debris that Joe talks about, again, way ahead of his time, is known to be filled with germs and other things that can cause fluid fill-up, influenza, pneumonia, etc. So Joe is way ahead of his time, knowing that through good exercise and movement, we can facilitate breath, and the breath can facilitate movement. Let's take a look first at the bony anatomy of breath. We often refer to this as the rib cage or the thoracic cage. The word cage to me sometimes has a negative connotation, sort of like an 800-pound gorilla behind a cage. That kind of cage, I hope, never moves if I'm on the other side. But in the rib cage, it's actually really supple and flexible and springy. If you think about it as being 12 articulating vertebrae, each one of them being able to move in all planes of movement could facilitate a tremendous amount of movement, and then attached to 12 flexible ribs on each side, and then in the front attached through rubbery cartilage to a floating bone called the sternum. So we have this almost more of a flexible basket that's designed to protect our vital organs, but at the same time, the movement of the rib cage is what facilitates the change of air in our lungs. When we look at the muscles of inspiration, the primary muscle is the diaphragm. There's no question about it. And the diaphragm sits inside of the rib cage and attaches to the bottom of the entire rib cage. So if we think of the front up here where T7 and the rib comes into the sternal process here, that is very high. And the diaphragm sits like a dome inside the chest. So if we look at the slide, you can see the white part, that's the aponeurosis. And this aponeurosis connects to the pleura, and the pleura creates a sac that goes around the lung. So when the diaphragm descends and goes down, it creates a vacuum or a negative pressure in the lungs. So if I open my mouth or my throat, air comes in as the diaphragm descends. Another unique thing about the diaphragm is it has what's called a central tendon. So right in the center, if we look up from the bottom on the other part of the slide, we can see that that tendon is a springy aponeurosis as well. So when the muscles pull down and it relaxes, it actually springs back up into its dome position. So after I take a deep breath in, all I have to do is relax, and the diaphragm will spring back up, pressing the air out of the mouth or the nose. Some other unique things about the diaphragm that make this such a special muscle is what we refer to as the cruce. If we look at the diagram of the diaphragm, you'll notice that the holes where the arteries, the vein, and the esophagus pass through, there are these muscular tendons that come down and attach to the front of the spine. Now, there's been a lot of good research, particularly by Paul Hodges, that has shown that these tendons, these muscles come down and play a very important role in the stability of the spine, which we'll talk about in axial elongation. But just paying attention to that principle, think of how that diaphragm sits inside our rib cage at a diagonal. When it comes down, it's going to flatten out, and it's going to push the viscera, the stomach, the liver, the kidneys, the intestines. It's going to push them down and out. Okay? Very important. There's not like there's air or space underneath it. It's going to push it down and out. When it relaxes, it'll come back up. So one of the false interpretations of a term called the powerhouse in Pilates is that we have to always hold these muscles in. Well, if we always hold these muscles in, we'll realize very quickly that that's not physiologically sound. All muscles need to contract and need to relax to be healthy. If I'm always holding the muscle in, I might end up with something that's called a contracture, where there's actually no movement, and the poor diaphragm cannot descend because the abdominal content, the stomach, the intestines, the liver, have nowhere to go. So the first lesson about healthy breathing is it's okay to let your abdominal wall distend when you're inhaling with your diaphragm. That is normal and healthy. Sometimes when we load it up, we have to use those abdominal muscles, and we'll talk about that a little bit later. One of the interesting things in the anatomy before I move on is the relationship between the connectors of the thorax with the abdominal cavity. If you make note, you can see the vena cava, which brings the blood supply from the lower extremities and the abdomen up into the heart and the lungs. You have the descending aorta, which brings all the fresh blood supply to the lower extremities into the viscera. And you also have the esophagus, which basically is the way that we get food and elements down into our stomach and into our digestive system. So those elements as well, those systems of our body, are greatly affected by our quality and ability to breathe efficiently with our diaphragm. Some people have what's called active insufficiency in the diaphragm. It just doesn't drop down or doesn't move very well. It's almost like a spasm. And that would, you can imagine, affect the flow of blood and affect the flow of food in our body between those two cavities. When we look at other muscles, and particularly muscles of inspiration, we talk about the external intercostals. Now, the way that we remember the external intercostals is that anything with external on it, external obliques or external intercostals, are going to run like you're putting your hands into your pockets, okay? And the external intercostals are more often found in the upper ribs, from like T5, T6, and above. And the reason being is that when they contract, they actually lift the upper ribs up, and there has to be a co-contraction down lower holding the lower ribs down to be able to get the ribs to open. Now, as you can imagine, when you open those ribs, you're going to create, again, a vacuum inside the lung tissue because you're opening something up and there's no place for it to go. It's going to be a negative pressure. And when you open your mouth or your nose, that would facilitate an inhalation. So another inspiratory muscle are the external intercostal muscles, and they actually expand the rib cage in the front and on the side to increase the vacuum and increasing the pressure, facilitating inhalation. Very important to remember that. Muscles of inspiration also include the accessory muscles of breathing. Now, the word accessory really sort of defines it point blank. The only time these muscles should work in a healthy individual is when you need a little bit of extra oxygen, and it is accessory. When we use these muscles, the sternocleidomastoid in the neck and the scalenii and some of the other small strap muscles in the cervical spine, to lift our top rib up to try to displace the lung, it is not an efficient primary strategy to breathe. It could be used in a very efficient way of an elite athlete, for example, at the end of a marathon, looking for those couple extra molecules of oxygen to make it across the cross line. But if it was your primary source of breathing, that would be a problem. Sometimes, too, when people have spinal cord injuries that are pretty high up around C3 and C2, the only way that they can breathe independently is with their accessory muscles. You'll often see this also as a faulty movement pattern with people that are smokers or poor posture or severe osteoporosis. Collapsed posture often will facilitate just using the anterior cervical muscles to breathe. The muscles of expiration are primarily your abdominal and lower back muscles. Anything that narrows the rib cage or draws it closer to the central axis is going to increase the pressure inside the lungs. and facilitate exhalation. This facilitation of exhalation is often done with a lot of our abdominal exercises in the Pilates work. So we think of contracting all of the abdominals, the rectus, the obliques, the transverse abdominis, the quadratus lumborum, all of these muscles together, depending on the organization of our body and space, can spontaneously force the air out of our lungs by increasing the pressure in the lungs, narrowing that space. Just to reiterate that muscles that connect to the ribs and the diaphragm are going to facilitate a change in the pressure inside the lung. So we said that the diaphragm and the external intercostal muscles are actually going to decrease the pressure in the lung, creating a vacuum, which would facilitate inhalation. We said that the abdominal muscles and some of the back muscles and the internal intercostal muscles are going to create a narrowing of the rib cage, which would increase the pressure inside the lungs and facilitate exhalation. Another area that is worth talking about is another diaphragm in our body, and that is actually our pelvic floor. The pelvic floor is the other end of the diaphragm that we breathe with, and they sort of create this cavity that contains all of our viscera. So our stomach, our liver, our kidneys, our intestines, the spleen, all of these organs are contained between the diaphragm that we breathe with and the pelvic floor. The pelvic floor is made up of a number of muscles, but one in particular that I want to share with you is part of the pelvic sling, or the pelvic floor sling, which is the pubococcygeus muscle. And just like the name says, pubococcygeus, the muscle connects to the pubic bone, the pubic rami. It surrounds the sphincter muscles like a sling, and then comes and connects to the coccygeus area, which is the coccyx or the sacrum, and actually comes up into the connective fibers of the anterior longitudinal ligament. Now you might ask, why do I bring that up? Remember how I said the diaphragm actually has slips, or the cruces, that come down and attach to the anterior longitudinal ligament at about L4 and sometimes even L5, and the pubococcygeus comes up and attaches to the anterior longitudinal ligament fibers around the sacrum in L5 and even sometimes up as high as L4. So if you imagine the angle of the pelvic floor and the angle of the diaphragm, both look almost like a mouth opening to the front. And this is why the abdominal muscles and that anterior connection of the rib cage to the pelvis is so important in the work that we do. It's not about the core control, it's about connectedness and control of the whole body. And we'll talk more about that in the second principle. But it begins here because breathing facilitates control of these muscles and these body parts. And if we use our breathing correctly, we can facilitate really efficient and spontaneous movement like Joe talked about in the earlier principles. The physiology of breath sometimes can be a little complicated, and my goal is to make it as easy as possible. The bottom line to this is that we're basically exchanging air. What's inside that air? Well, we know there's many inert elements inside the air, like nitrogen, but we also know that the primary things that our body works off of, that it needs, is oxygen. And oxygen is balanced out with what we call carbon dioxide. So you know, in the world of ecology, plants put off oxygen, we drink or breathe in the oxygen, we put out CO2 or carbon dioxide, and plants absorb CO2 and carbon dioxide. So we have this beautiful relationship with plants around the world. And that's how we generate this chemical, or this air of oxygen and CO2. What happens is when we bring air in, we talk about this as being the internal breathing. We talked a little bit about external breathing with the ribs and the lungs. The internal breathing has to do with chemical exchange of oxygen with CO2. So as the blood runs through our body full of oxygen, the tissues in our body, and our organs, our muscles, our bones, our fascia, absorb the oxygen as energy. And the waste product of used oxygen is CO2. The CO2 is then brought back towards our heart through the lungs in what is called the venous return. So the veins return all of this used blood. We often refer to it as blue blood when it doesn't have oxygen. That's why you'll see the veins being depicted as blue and the arteries depicted as red. It brings this blue blood back towards the lungs, and it diffuses it into what are called the alveoli. Now, the alveoli are small air sacs inside our lung that have a very thin membrane. And the veins bring the old blood in, and there's an exchange between the CO2 and the O2. And the hemoglobin attracts the new oxygen and gives off the CO2. And then when we blow the air out of our lungs, we blow off the CO2, and the new rich oxygen blood goes into our heart and gets pumped out to all of our body tissues again. And that repeats itself thousands and millions of times in our life. Okay? So one of the things we want to remember here is that the actual exchange of gases only takes place in the alveoli of the lungs. Some people talk about air exchanging in our skin or our eyes or our pores, and that's just not true. The air exchange of gas only happens in our lungs, in the alveoli tissue. So we look at the way of understanding air exchange and how that works in our body and what drives us to breathe. And we start going over some terminology that I think will be helpful for us to understand the physiology of breath. The first term I want to teach or share with you or review with you is total lung capacity. This is measuring the total inspiratory capacity, like if we filled our lungs up to the maximum that we could, and the total expiratory capacity. So we blow the air out all the way out until there's no more air in our lungs. And we added that together. That would be the total lung capacity. Our inspiratory capacity is the amount of air in our lungs as at max inspiration. So how many liters of air can we hold in our lungs or bring into our lungs? The inspiratory reserve is additional air that can be inspired beyond what is referred to as the tidal volume. So I want you to think, as you're sitting here listening to this lecture, you're breathing and you're not thinking about it unless I'm bringing your attention to it. The tidal volume is just your natural in and exhale that often is relaxed. So there's a little contraction of your diaphragm, and then there's a relaxation of your diaphragm. And that exchange of that contraction and relaxation is enough to exchange enough air, enough oxygen and CO2 to be able to be conscious and be alert and do the things that you're doing. We refer to that as tidal volume. Okay? When I breathe beyond the tidal volume, so I did my little inhale, and then I say, I really want a lot of air in, so I'm going to bring in a lot more air into my lungs. I'm going to fill up what's called the inspiratory reserve. And then once again, as I relax, that goes back down to tidal volume. If I go into a forced exhalation after that relaxation, is what's referred to as the expiratory reserve. This is additional air that can be expired beyond the tidal volume. So it's important for us to understand in Pilates, because we talk about, Joe said, forced exhalation, to really clean those lungs out and to take full deep breaths in. He's not talking about tidal volume. He's talking about getting that maximal inspiratory reserve and the maximal expiratory reserve in our exercise program. This is what we would refer to as breath-emphasized Pilates. We need to make sure that some part of our exercise, not for the exchange of gases, but merely for the cleansing, or what Joe referred to as the internal shower, right? Getting all the old waste products out of our body. So tidal volume is that amount of air breathed in and out during relaxed breath. Vital capacity is tidal volume plus inspiratory plus expiratory volume. So we look at that whole exchange. Now there's one other thing in here that sometimes is confusing, and we refer to this as residual volume. I don't know if you've ever done this or not, but I definitely have. I fell out of a tree or fell off a diving board and hit the ground or the water so hard that it knocked the wind out of me. And I couldn't catch my breath, and I was in that state of that is the residual volume. Joseph Pilates was not talking about pushing out the residual volume or we'd all be passing out. He was talking about the expiratory reserve, and after the expiratory reserve is out, there still is a little bit of air inside our lungs that is called the residual volume. Hyperventilation is an interesting phenomena in the human body. Because the CO2 is really what determines whether we breathe or not, When the CO2 gets really high in our body, we experience what's called vasodilation, which means it wants to bring more oxygen to the tissues. It also facilitates digestion and thought and clarity. Conversely, if we breathe too much and the CO2 goes down and the oxygen goes up, we experience a vasoconstriction, which is going to decrease the amount of oxygen that gets to the brain and decrease the amount of oxygen that gets to our digestive system and to our muscles. And often what we experience is a lightheadedness or a dizziness. This is a common mistake. It's not a real vital one, but it is a common mistake amongst new Pilates teachers that will tend to teach breath as a rule so much that they overbreathe their clients in very basic exercises. And what I want to make clear here is that there are exercises like the hundreds and other exercises that use large muscles and use them over time and requires vigorous breath that matches the activity of the muscles in the body. And following that activity, they're not going to experience hyperventilation or any dizziness. However, if you use that same intensity of breath that you did on that more vigorous exercise on a less vigorous exercise, it's very likely that you might have an experience with your client of lightheadedness or dizziness, or in some cases even passing out. And we want you to avoid that. So one of the things we talk about in Polestar is that breath is a tool, not a rule. We use our breath to facilitate movement, and we use our breath to be able to organize the body efficiently. So overbreathing would not be efficient. On the same token, we do have breath-emphasized exercises that are going to use large muscles and really emphasize that complete inhalation and that complete exhalation multiple times to achieve what Joe talked about of the internal shower.